Hi everyone, my name is Afua Kunadu. I'm a pulmonary and critical care fellow at East Carolina University at Vidant Medical Center in North Carolina, and I'm grateful for the opportunity to present this interesting case of ascending paraparesis following the use of Nintedanib. I don't have any financial or ethical conflicts to disclose. Just as a background, idiopathic pulmonary fibrosis, as we know it, is an incurable progressive fibrosing interstitial lung disease, usually characterized by dyspnea, cough, reduced exercise tolerance, and a progressive decline in lung function. Overall, it tends to have a very poor prognosis with a median survival anywhere from 2 to 3 years. Predominantly, you find elderly people being affected between the ages of 50 to 70, but this can occur also in younger population, mainly those who have a genetic predisposition to syndromes like the short telomere syndrome. Now, Nintedanib is one of 2 antifibrotic therapies approved for the treatment of IPF, and it's shown to reduce the rate of decline in forced vital capacity. The commonest reported side effect is diarrhea. However, there hasn't been any significant neurological side effect reported. So to our case, we had a 39-year-old gentleman with history of familial IPF secondary to short telomere syndrome, for which he was started on Nintedanib. 24 hours after taking his first dose, he developed paresthesias in his fingers and toes, which progressed to numbness and weakness of all extremities by day 4 when he came to the hospital. He also reported associated extreme fatigue, pain in his leg, and back pain. He denied any preceding upper respiratory tract symptoms, but had 3 loose stools on the first day of his symptoms, but this had spontaneously resolved by the time he presented. On physical exam, he had bibasilar fine Velcro crackles, normal muscle bulk, but he was found to be hyporeflexic and he had a flaccid tone in all extremities. He also was noted to have fasciculations in the lower extremities. Power was 3/5 in all the extremities, and sensation was impaired to pinprick. He had extensive workup, mostly normal, autoimmune workup negative. Vitamin B1 levels were low and IgG levels were marginally decreased, basically the subclass 3. Cultures were negative. We did a lumbar puncture, which was also unremarkable, normal protein and normal WBC count. MRI brain and spine were normal. He had an EMG, which showed motor polyneuropathy involving the upper extremities with limited demyelinating features, and this was consistent with Guillain-Barré. As far as his management was concerned, overall, he took a total of 4 doses of Nintedanib before it was discontinued due to concerns that what we were seeing was a side effect of the medication. He regained his muscle strength with supportive management, mainly through physical therapy. He did not get any immunoglobulin, and he did not get any plasmapheresis. At the day of discharge, on day 6 of admission, he was able to ambulate with minimal help from rollator walker, but he still had some significant issues with fine motor skills. Over the next couple of weeks, however, he did get back to baseline with physical therapy at home. So Nintedanib is a tyrosine kinase inhibitor which targets growth factors like vascular, endothelial, fibroblast, and platelet-derived growth factors. These have all been implicated in the pathogenesis of IPF. Along with other TKIs, it's been reported to have some rare neurological side effects like dizziness and headaches. Nintedanib, which is another TKI, has been shown to cause a myasthenic-like syndrome, mainly through neuromuscular junction toxicity. Sunitinib has been shown in several studies to cause a Guillain-Barré-like syndrome. Now, the neurological side effects of Nintedanib during experimental phases in rats and dogs had it reported that these animals had some abnormal gait. They were found to be staggering after they got certain doses of the then experimental drug that we now know to be Nintedanib. But it looked like this resolved and nothing further was mentioned in those experimental studies. The mechanism by which nintedanib may have caused ascending paraparesis is still unclear, but we think that similar to sunitinib, it may be through inhibitory extracellular action against vascular endothelial growth factor receptors, thereby increasing the levels of VEGF, which again is commonly associated with development of different neuropathies. Now, with the increasing use of nintedanib, it's inevitable that previously unknown and unreported side effects will come to bear, and these will need to be further studied. To the best of our knowledge, this is the first reported case of ascending paraparesis following the use of nintedanib, and we thought it would be interesting to share this case. Thank you for the opportunity. Thank you.